Hello there, listeners. It's Susie New here. Thank you for listening to the Australian Anesthesia podcast, where I want you to today make a pledge with me, and that is no more S word. And that will make more sense in a bit, because in this episode, I'm chatting with Associate Professor Allan Cyna, whose name, if you've ever looked into communication, nocebo language, or hypnosis, you'll be very familiar with. And you might be able to guess what the S word is that I'm referring to. Communication, as you may have guessed, is a real interest of mine. I wouldn't say I'm an expert at it, because what's the first thing I do when I hear someone is an expert? I look for examples of their expertise, and also when they might not appear to be so expert. And communication is a tough one, because we all communicate. We've all had years of experience of communicating, and when you've had years of experience doing something, you might think that you're doing a pretty reasonable job. Nevertheless, I really like learning about communication, whether it's within and between organisations and people, in print or in social media, public speaking. But I particularly like learning about communicating with patients, especially when I see it being done well. And often, whether it's public or patient-facing communication, I might even try to mimic what I've seen just to try it on. And I make that distinction here about seeing it done well, because I'm really big on visuals as well. I've been wanting to do a podcast with Associate Professor Cyna for a while, but what really tipped me is seeing his keynote presentation at the NSC, the National Scientific Congress organised by the Australian Society of Anaesthetists, where he showed, now it's been a year, I'm talking about the Congress last year in Canberra, but I recall he had these really impressive videos of himself anaesthetising children calmly, using suggestion and hypnotic language. And for anyone who anaesthetises children, don't we all want that? Whether we have the skills to transform a crying child to one who is calm and cooperative is one thing, and you'll hear about my attempt to do this during our conversation in this podcast. But I do think that any doctor, nurse, paramedic who wields a needle can do some really simple things to make the experience more comfortable for patients, whether they're children or adults. And it's not just about inserting cannulas, but the whole experience of surgery and anaesthesia, or any type of procedure really. To me, it's one of those no-brainers. If you can do an intervention that doesn't cost anything, but it could improve outcomes and there's no real side effects, then why not give it a go? And using better communication, avoiding nocebo language, using positive suggestion, that ticks all of those boxes. If we get it wrong, if we don't do it, if we use nocebo language, we can worsen that experience for patients, and we can even worsen outcomes. I always feel inspired to improve my communication game whenever I chat with Associate Professor Cyna, and I hope that's how you find this conversation too. Let's get into it. So today we're talking about hypnosis. I went to your talk last year at the NSC, and obviously doing paediatrics, you're always trying to improve your communication game and see whether there's things that we can do just using our words that means we don't have to resort to force or overuse of sedation or things like that. I think It's one of the things that we can do to get better as anaesthetists. But I'm curious to hear from you, first of all. How did you get interested in hypnosis?
Well, probably started as a medical student when a senior anaesthetist gave an evening lecture to my class, and he drew a sort of circle on the blackboard with some chalk with a sort of square in, and just asked us to focus in the centre of the circle. And within about 30 seconds, I felt my eyes feeling really heavy. And he said, look, we've got 6 people in trance, so if the rest of you can come back into the room, that'll be fine. And there were 6 people who I knew quite well who were in the group, and they just looked like they were asleep. And he proceeded to elicit hypnotic phenomena like arm levitation, arm anesthesia, pop some needles along their arm, and they didn't seem to notice it. He did an age regression of one of my fellow medical students, and he age regressed her back to when she was 5, and then she started talking like a child. And he asked her to go back to a happy event, and she started giggling, and someone had apparently fallen in a puddle. It was as if she was there at a birthday party.
Wow.
And then he asked her what she wanted to do when she grew up, and she said, a teacher. And he said, don't you want to be a doctor? And she said in a sort of child voice, "I don't like doctors." Anyway, he reversed the trance. And it wasn't until I came to Adelaide that Graham Wicks, who was a GP hypnotherapist, he was there for 35 years doing really interesting things with hypnosis, like minimizing symptoms of chemotherapy, putting in really big dialysis catheters, all sorts of things in children using hypnosis for all sorts of quite major procedures that normally people wouldn't tolerate without an anaesthetic. So that really generated interest. And he was one of the founding members of the Australian Society of Hypnosis, and he ran the course in Adelaide.
And so when did you start learning the practice of hypnosis?
Around 2002.
What age were you in your career at that point?
I'd already been a consultant. I was a consultant in the UK before I came here.
I see.
In 97. And I'd always been interested in research. I was the worst communicator. I used to really upset everybody.
Can't believe that.
So as soon as I started doing the course, it just made me really appreciate how often we were using negative suggestions in acute care. And then that really generated my interest.
Can you give me an example of a negative suggestion that we might use?
Yeah. But when you inject local anaesthetic and you say this is going to sting.
Oh, all the time, Alan, I hear that.
There's now really good evidence that using such negative perceptual language increases anxiety and pain. And we actually did one of the first studies at the Women's and Children's with drip insertion because the standard language was sting.
Yeah, what was your study?
We basically randomized just a drip insertion before surgery. We randomized patients to either receive the standard language or just saying we were positioning the drip. And the people who used the negative perceptual language had more vocalizations of pain, more movements of the arm. And although it wasn't a significant difference in pain scores, it was definitely in the direction of lower pain scores if you avoided the sting word. And that study was published in 2007, I think, in the British Journal of Anesthesia.
Fantastic. Congratulations on that. And you'll be pleased to know I mentioned it to a surgeon the other day. We were doing some procedures under local anaesthesia and he said, "This just a sting now." And I told him and he was very receptive. So we're slowly getting the word out there.
There's been actually 5 randomised trials since then showing really very similar results. The best one probably being in Boston Women's Hospital, where they used to say bee sting coming for local anaesthetic into the back for epidurals and spinals. And that showed very clearly significant reductions in pain scores if you avoided bee sting.
Yeah, even bee sting. And even I think since listening to you talk last year, I don't even say the propofol will feel cold or might feel cold.
I think just saying we're just giving you the anaesthetic and you'll be waking up in the recovery really soon. Just getting people to focus on what you're doing in terms of meaning rather than predicting a perceptual experience, which is always different for different people.
I'm going to segue for a bit here. I'm going to come back to my train of thought in a bit, but I did a podcast recently with a psychologist and I mentioned to her that concept of talking about where you want to be in the future, like you'll be comfortable in recovery and looking forward to having something to eat and drink. And she had the psychological term for it. It escapes me. It was a very technical term that I think they use it in, I'm going to get it wrong, but I think they use it in cognitive behavioral therapy or something like that. I'll have to go back and dig up the term and see, because I can see these cross linkages occurring.
It's fascinating that it's there and people know about it and often do have different language in different settings. We've become familiar now with the term nocebo effects, and that's very much to do with negative effects of these suggestions of changes in perception.
Like the word sting.
Yeah. But the suggestions are like verbal or non-verbal cues that can lead to a sort of subconscious, non-volitional change in perception or behaviour or mood.
Oh, tell me about the non-verbal cues. I didn't know about that.
So if you hand someone a sick bowl, for example, and they're not feeling sick, there will be a proportion of patients who will start feeling nauseous or they'll start vomiting. It's really important to, if you've got someone that doesn't look like they're nauseous or they've and you haven't asked them about that.
Yeah.
Probably best to avoid having a sick bowl or sick bag near them.
Ah, interesting, because we would often think of that as being something preemptive.
Well, it's good to have it maybe behind them, out of their vision field. Yeah.
All right. That is good. I'm always learning when I speak with you, Alan. While we're talking about psychology, and I will get back to my original line of thought, but when you mentioned the lecturer that you had at university and he regressed someone back to when they were 5, one of my concerns, but also I think just people's concerns in general, what if you go back and unmask something traumatic?
Yes, look, that's really important. And certainly in training, we're very particular about using that technique. And there are ways of avoiding going back to a traumatic experience by asking someone to go back to a happy memory or a happy experience or something that they found interesting or funny in their childhood. And you can certainly do it that way. This wouldn't happen in anesthetic practice just by conversational hypnosis, but people can sometimes develop an abreaction, and it's very important to deepen the hypnosis at that point until the reaction dissipates. That's something we teach people how to do on the course that we run.
That sounds so phenomenal and a little bit daunting to learn about. But do you find that, for example, I'll often see children and they would have had a traumatic experience with a previous anaesthetic.
Sure.
And they're now either needle phobic or they're even too scared to come into the theatre. As soon as they see us in scrubs, it sets them off. I've referred children like that, particularly if they're coming for repeat procedures, to see if they would be a good candidate for hypnosis. But in managing that, would you then need to go back, or say if they're an adult even, go back to that traumatic experience?
Look, as anaesthetists, we'd rarely use that technique. Okay. And it's usually with adults who've had maybe 35 years of severe needle phobia, something like that. It can be useful. But generally, especially with children, we wouldn't use that technique at all. For children, there's a whole load of other things that they can do, especially between the ages of 4 and 10. There's some really powerful skills they have that older children and adults don't have.
It's probably got a lot to do with their imaginative thinking.
Exactly. They're in a hypnotic state most of the time, make-believe, play world.
I suppose what I'm getting from this little bit of conversation so far is I think of hypnosis as a blanket term. What I'm hearing is there's actually lots of different components to it.
Yeah. People generally think of hypnosis in maybe the way we would give an anesthetic, an induction, maintenance, some form of treatment, and then alerting procedure. And for formal hypnosis, that framework fits quite well. In anesthesia, 95% of the stuff generally would be conversational hypnosis, where when patients are anxious, they're really in a trance-like state anyway, without a formal induction, and become very vulnerable to suggestion, whether they're positive or negative. So we can sort of utilize suggestion in a therapeutic way rather than inadvertently in nocebo effects, which traditionally is what happened when we describe perceptual behavioral experiences in a negative way.
I see. So just through our everyday conversation, we're not doing the full hypnosis, but we're introducing elements that can help, I suppose, progress.
Yeah, in our daily lives, we're in and out of a hypnotic state maybe 200 or 300 times a day. If you drive your car home and you find yourself suddenly at home without remembering most of the journey, it doesn't mean you were unconscious or not driving safely, but you were in an automatic trance-like state maybe. And this frees the mind up to do logical things.
That's so fascinating.
And in fact, it's the way we learn. In learning to drive a geared car, for example, so much of your energy is concentrating on the clutch and changing gear and that you don't really enjoy the journey, but eventually you don't even notice yourself doing that naturally.
Now, speaking of enjoying where you're going, I want to go back to my original line of thought. So you were a consultant already in the UK. You came out to Australia, to Adelaide, and you started learning hypnosis there. Is that right?
Yes, yeah.
And was that through a formal course?
Yeah, so basically the Australian Society of Hypnosis at the time had a South Australian branch, and that was run by some really skilled clinical hypnotherapists consisting of GPs, dentists, mostly. I don't think there were any anaesthetists at the time teaching on the course. They had certainly clinical psychologists. And yeah, it was a 2-year course at the time, and we weren't actually allowed to do hypnosis for the first year.
Wow.
It was sort of a part-time thing.
Yeah.
And now we just run 6 weekends over the year, and we teach people hypnosis right from the word go, basically.
This is the advanced training in clinical hypnosis that you are running.
Yes.
And it's called advanced training. So does that mean I should have done some beginner training first before I
No, we
enroll?
actually take people right through from complete novices to, I mean, some people are quite experienced when they do the training with us. Others are complete novices. And I think as long as they've got professional training in healthcare, APRA registered, we take them, basically.
Okay. The course starts early in the year?
Usually mid-February. There's a full weekend in February, and then we do miss a weekend or two, and then there's the second 2 days. And then it's every 6 weeks or so through the year till November.
Does that mean I'm going to sound like you afterwards? Because I've seen your videos and I think they're fantastic. I want to induce my patients like you do.
You will sound like you. I think one of the really important things is to find your own language. There's underlying language structures that are cross-contextual and across age groups. So there's fundamental principles, but people within those principles then find their own language that works for them. I think when I did the course initially, I must have bought 100 books over the 2 years. There was so much out there. And once I started, I was like a complete addict. So there's a lot of different scripts. So there's a lot of really interesting practitioners out there that have written some really amazing things. So yeah, and I've never stopped learning. I learn something new with every patient, really.
So you did the course in 2002. And you're now a teacher on the course?
Yes, I've sort of been running the course for the last 14 years.
Wow.
But we have about 23 teaching faculty from various fields, psychology, dental, anaesthetists. There's a whole range of different people who teach on the course. I'm
doing the math because how long does it take, once you do this course, how long does it take to get mastery? What does that journey look like? You're
pretty competent by the time the course finishes. Most people start using hypnosis after the first 1 or 2 weekends.
Really?
Yeah. But it really is probably 4 or 5 years after the course that you become really fluent. So it does take a bit of time. And a lot of the things make more sense the more you do. There's a lot of stuff going on during the course that people click in around day 9, 10 usually, how the first 4 days fit into clinical practice. I mean, you've started using hypnotic techniques already, obviously with suggestion and all this sort of thing. So it's really just dipping your toes in the water, getting familiar, and then just trying different things with patients and seeing how you go with them. But it is a bit of a leap of faith initially.
I had a recent experience. I had a child who needed an MRI and he had already been down to the MRI. They'd already tried to do it without any sedation or anything and they weren't unable to do it. And he came down again and we couldn't even get him into that first room. He was so triggered and started crying and was very distressed. And I somehow managed to get him to the point of letting me put a tourniquet on his arm and even attempting cannulation, at which point I missed the cannula. and even despite the EMLA, he felt the cannula go in. And I thought, if I just had that next level where I could make the magic glove or the arm go numb, that further dissociation, I was almost there.
But it's amazing you got as far as you did. Do you remember what you did to achieve that?
I took him back to, first of all, a place of comfort. So I took him back to his bed in his dad's lap and we just said, we're just going to sit you here. That's okay. Then I borrowed all of your techniques, Allan. So I tried to use familiar language to him. So I said, I've got this colourful stretchy band and I showed him and I stretched and I said, can I put it on your arm? Is that okay? And so each step I asked him for approval. And then I started using words instead of your arm, it became the arm. And so I started trying to say, okay, now the arm's starting to feel heavy. Can I tighten the band? And then I got the alcohol swab and I said, this will help soothe the skin. Can I wipe the arm? So I was trying to dissociate. So I tried. That were the main techniques I used.
It sounds like it really worked. And and sometimes missing a drip, patients are amazingly resilient if they've allowed you to get that far. And often you can ask them if it's okay to finish.
He lost it then. I thought I hadn't dissociated him enough from
Well,
or maybe,
I
I don't
don't
know.
know.
I ran out of tools in my tool belt.
I mean, it sounded like you did really well
Oh, thank you.
for someone like that in an acute setting.
Always room for improvement. I want to mention that you've done a PhD somewhere along the line, and I'm going to assume it was in hypnosis, but please correct me.
It was.
Yeah.
Look, I was really lucky. I mean, working at the Women's and Children's, pregnant women and children are probably the most receptive or hypnotizable populations.
Really?
Yeah, the neurobiological changes that occur in pregnancy allows dissociation. So that when you're in labour, it becomes much easier for women to dissociate from contractions.
Interesting.
And a lot of the physiological changes are really adapting to childbirth in a way that allows contractions to be experienced in a more comfortable way anyway. And that's why in pregnancy, for example, they require less anaesthetic when they're pregnant than when they're non-pregnant. It's because of this increased hypnotisability that they develop. And in fact, we showed this as part of my PhD. We did a side study measuring hypnotisability at 34 weeks. And then when the women were no longer pregnant, and they were much higher scores in hypnotisability when they were pregnant than when they were subsequently no longer pregnant.
So the same women were examined during pregnancy and then after, or in a non-pregnant state. Fascinating. Speaking about hypnotisability, do you meet people who are just unable to be hypnotised?
Look, I don't think people could function in the world if they didn't have this ability to utilise hypnosis. For standard hypnotic techniques, there is a sort of bell-shaped curve of abilities. About a third of patients, for example, could have abdominal surgery using hypnosis. About 90% of people will respond in some helpful way with standard techniques. And then the remaining patients will just need something slightly different than the thing that works with most people. So it's why it's really useful to learn a whole range of different skills so that when you come across someone who doesn't respond in a way that's maximally helpful to them, you can actually just readjust and go to a whole range of different things and see what works.
Do you find that sedation impairs or impacts the ability to hypnotise someone?
I think, well, there are Liège in Belgium, they do hypnosis, sedation and local anaesthetic for head and neck surgery.
Yes.
Things like that.
I've seen that video of the woman having thyroid surgery.
Yeah, they're really an interesting bunch there. Professor Feynmanville really led that team.
Wow.
And she's done really thousands of patients now using hypnosis, avoiding a GA. I think the GA rate initially for those patients was 100%, and it went down to about 8%. And people were just expecting to have hypnosis and local, basically. My experience is sedation tends to make things a little bit more difficult for me. I think it's because hypnosis is a conscious state. There's much better focus if there's not sedation, I think. I mean, fentanyl's probably okay if you need some analgesia, but like midazolam or propofol probably makes hypnosis more difficult or less effective, if you like.
Have you ever been asked to do hypnosis for someone having surgery?
Yeah, quite a few times. We did write a case up in the Australian and New Zealand Journal of O&G of a lady who had a football-sized vulval hematoma after giving birth at home and required surgery, but she'd lost about 2.5 litres and had a coagulopathy at the time. And she was needing to go to theatre and she was refusing to have a general anaesthetic. And we couldn't give a spinal because of a coagulopathy.
Yeah.
And I did offer her hypnosis, which she was really keen on, but only after she also agreed to allow me to do a GA if she needed one. We did the whole case pretty well with just hypnosis and I think 100 mics of fentanyl. And she had a Bakri balloon. It was a 2-hour procedure and she did really well. And she had a lower body hypnotic anesthesia.
Wow, that's incredible.
But when people are in that acute frame of mind, they are very receptive. I mean, stress increases hypnotic ability.
And the whole time during that surgery, you're with her helping to maintain her hypnotic state.
Yeah,
That's
so
your role?
basically,
Yeah.
I did the lived-in imagination technique. So she closed her eyes. I asked her to go to some place she was comfortable, and she just imagined herself on an upstairs bedroom with a newborn baby, and she described what she was seeing outside the window, and she could hear the children playing downstairs. And I just sort of followed her lead with deepening that experience, and then gave suggestions for lower body anesthesia. And she actually developed that.
You know, there'll be some people who'll be listening and they'll say, it seems like woo.
Well, it does sound like woo-woo, and you're quite right. And a lot of people still think I'm crazy. But,
I don't.
but there's now really good clinical and neurobiological evidence with functional MRIs, and the effects of suggestion can be imaged. And hypnosis can be imaged, the new brain imagery techniques we have. So there's a lot of research on this, and there's some real consistent findings with what happens with a negative suggestion versus a therapeutic suggestion, for example.
Yeah. I feel like I'm talking to an encyclopedia on hypnosis when I chat with you. Is there anything I haven't asked, anything I should be asking you?
I think, what can people do right now if they've never had any training?
That's a great question.
I think the first thing people can do is really think about listening for what people say to patients and listen for inadvertent negative suggestions, things that might be unhelpful. This will make you jump. This will hurt. This won't hurt. So when you're describing a perception in a negative way, that can be changed simply by either avoiding in your own language or by just explaining to patients the meaning behind what you're doing, even if you think it's potentially painful. So, for example, if you're putting a drip in and you think it's going to hurt, you can just say, would it be okay to position your drip so that we can rehydrate you, give you some medication to get you comfortable, maybe to allow you to eat and drink a bit sooner, and just keep you safe? Would that be okay just to finish putting the drip in for you? And we'll let you know when we're done, or something like that, rather than trying to predict an experience for them.
Yeah. That does remind me of the podcast I did on trauma-informed care with the psychologist. And it was along the lines of, you can't predict what their experience is going to be, so we shouldn't give them the language or the imagery. It's like when you're putting a needle in a child and we might say, don't look. But in fact, some children want to look. They're happy to look and it doesn't bother them. So we're sort of imposing our values on that experience.
Absolutely. And that's the thing. Patients are really good at letting you know what they can do. If they say, I can do it, believe them. I've had young children of 5 or 6 say, oh, you know, you tell them you can find a wire to a different part of their body and they can switch it off so they don't feel anything. And if they say they can do it, they'll just do it.
That is fascinating. Is there anything else that you would like to tell us about hypnosis education with patients?
Look, I think reading some of the implications of nocebo is useful because that does really help. And we did an article in Anesthesia in, I think, 22 on the implications of nocebo. And we did have a lot of ideas in that on things you can do. And we did one for British Journal of Anesthesia Education in 24, which, if people are interested, it's called Practical Hypnosis for Anaesthetists, something like that. And that gives quite a few ideas on how you might want to integrate this sort of language into your clinical practice.
I'll try and find those articles and I'll see if I can put a link to them in the show notes for this podcast. But I think that's a great take-home message is let's try and minimise our use of the nocebo language and maybe even educate our surgeons about it too. Well, look, it's been great chatting with you today, Allan. Thank you so much for your time.
Thanks, Susie. I really appreciated being invited to talk.
Well, are you feeling inspired? I hope so. I have many resources to share with you. During our chat, I mentioned a podcast I did on trauma-informed care with clinical psychologist Bridget Berry. I did go back and listen to it to remind myself of the term that she used, which I couldn't recall in my conversation with Allan, and that was dialectical behaviour therapy. If you want to learn more about that, that's in episode 118 of this Australian Anesthesia podcast. I've also done an earlier podcast on hypnosis focusing on children, and that was with the then president of the Australian Society of Hypnosis, Dr. Annette Webb, and dentist Dr. James Auld. That's in episode 55. As I mentioned at the start, Allan spoke at last year's ASA's National Scientific Congress. ASA members, you can log into the ASA website and catch up with talks from that Congress. I think Allan's keynote presentation, as well as the other keynotes, they are scheduled to be uploaded to the website in September. Now, speaking of NSCs, why wait a year before you can watch the video when you can see these talks live and be there to interact with speakers and other conference goers, and perhaps even give me some clues as to who to feature on the podcast? This year's NSC is being held in conjunction with the New Zealand Society of Anaesthetists, hence why it's called the Combined Scientific Congress, or CSE, rather than an NSC. Anyway, it's at the Hunter Valley and I've registered. I can't wait. I also have a host of resources to share on behalf of Allan. He is the director of the Advanced Training in Clinical Hypnosis course that we discussed. That's the one that runs throughout the year in 2027. If you are interested in that course, you can learn more and register on the South Australian Society of Hypnosis website. I'll put a link to it in the show notes. There's also a one-day introduction to hypnosis course that's being held later in this year. I think it's November sometime. Again, you'll find the details on that website. On that page, you'll find the link to the BJA article, the British Journal of Anesthesia article that he mentioned, which is titled Clinical Hypnosis and the Anaesthetist, A Practical Approach. The other article he mentioned was published in the journal Anesthesia and titled Implications of Nocebo in Anesthesia Care. And finally, Allan requested that I give a plug for the second edition of his book, The Handbook of Communication in Anesthesia Pain Management and Intensive Care, which came out in 2024, and big kudos to the Anscombe Library. It's available online now. Of course, there'll be links to everything in the show notes. By the way, did you work out what the S word was? That's right. Scratch or sting. You had two options. I would just love to not hear those words anymore. Sharp scratch coming, just a sting now, little bee sting. Let's just zip it up and encourage our colleagues to do the same. If you have any feedback about the podcast, then please email me on podcast@asa.org.au. I've really been enjoying some of the things that you share with me. Terry, Megan, you know who you are. A big thank you for listening, following the podcast, and also contacting me. All right, I could go on forever, but that wouldn't be my best communication, so I will leave you with the wish that all is safe and well for you and your patients. Thanks for listening.
This has been Australian Anaesthesia, produced by the Australian Society of Anaesthetists, with many thanks to host and editor Dr. Susie New, with music by Soda Lime Music, sound and engineering by Bearview, and graphics by the ASA Communications team. For more content, please visit www.asa.org.au.